All right, welcome and thank you for joining. My name is Ashley Lusick, and I am a health educator for community health at Atlantic Health System. Today's webinar, Eating Disorders 101, is presented by Megan Fian. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or chat for comments. We will try to get through all questions at the end of the presentation. Are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke free. There are multiple dates and times available, with groups available in person or virtually. For more information about these groups and other resources, or for additional dates and times, please call 1-844-472-8499. I am now going to turn it over to Megan.
Thank you so much, Ashley. So let me begin by sharing my slides. Okay, Ashley, good? Great. So a big thank you to Ashley for spearheading this program today. So it is Eating Disorder Awareness Week, which happens at the end of every February and the beginning of March, and really focus on getting the awareness about these illnesses. So thank you all for joining me today. So to talk a little bit about what we're going to discuss today, I'm going to go over the different diagnoses for the various eating disorders, speak a little bit about how we typically see eating disorders present here at our center, some of the causes of eating disorders, and the causes are there in quotes for a particular reason, which I'll get into when we discuss what those are. Some of the myths that we see associated with eating disorders, the psychological and the physical warning signs, some treatment options, as well as the impact of COVID on these illnesses. So to begin with, I'm going to go through the different criteria for the different eating disorders that we see. But overall, as a whole, what I really want people to understand is that eating disorders are biologically based illnesses. And I think that oftentimes surprises a lot of people to learn that there is sort of this genetic and biological underpinning to these illnesses. But the research indicates that it truly is some genetic makeup that makes individuals susceptible to these illnesses. And I will talk about that when we talk about some of the causal factors. But to also recognize that these illnesses are curable. And I think that that is really unique to say, because when we think of mental illness, typically, I think we think of learning to sort of adapt to and manage the symptoms associated with the mental illness. But eating disorders are slightly different in the sense that they are something that someone can go into full and complete remission from. So to begin with, I'll go through the criteria for anorexia, and you're going to hear me sort of reference what's known as the DSM. So the DSM is what psychologists and other mental health providers use in order to provide diagnosis for various mental illnesses. So it went through the most recent updates in 2015. And so some of the things that I'm going to speak about are comparing how we used to see anorexia prior to that date and how we look at it now. So the first criteria for anorexia is that an individual must be restricting their intake, their food intake, really in accordance with what their body requires, and it results in a low body weight. So prior to 2015, there had to be a specific number that people were below. And so specifically, an individual had to be 85% of their expected body weight or below in order to meet criteria for the diagnosis. So with the revision of the DSM-4, they got rid of that specific number weight requirement, because really, for various individuals, losing weight could be significant for them, even if it didn't meet that criteria. And so specifically in younger children and younger adolescents, for them, really any weight loss is truly significant because they're obviously supposed to be gaining weight and growing as they continue to develop. And so for individuals even who maybe have sort of a plateau in their weight, that can be significant, and that can be very much can be anorexia. So again, it's really about the behavior more and restricting one's intake. There's also an intense fear of gaining weight or persistent behavior that interferes with weight gain. So what was added in 2015 was this persistent behavior. And the reason why is because some individuals with anorexia actually tell you that they're not fearful of gaining weight. And really that speaks more to there's often a lack of insight into the illness. And so individuals may say that, but when they're required to actually gain weight, it's a challenge for them to do so. So even though they may verbalize, oh, I understand that I need to gain some weight, I'm not afraid of that, they still might be acting using restrictive behaviors in order to keep their weight suppressed. And so, again, it's not necessarily that they are verbalizing that fear, but their behavior show that the fear does exist. And finally, there's a disturbance in the way that one views their body. So sometimes it can be body image distortion. So that means that individuals are not seeing their body accurately. So despite being underweight, they don't see themselves as such. Or they might, what we call, have an over-evaluation of shape and appearance. And so meaning that when they're looking at factors that comprise their self-worth and how they feel about themselves, shape, appearance, and weight concerns really predominate. Or individuals may have a lack of recognition into the seriousness of their low body weight. Again, it's really a hallmark for this illness is not recognizing that the severeness of the malnutrition and the impact that it's having on the body system. So in general, about 0.5 to 2% of adolescents will suffer from anorexia. And the ratio for individuals is that typically in the older population, I would say older adolescents, young adults, we see a ratio more of for every 10 girls, 1 male is affected. That ratio is much smaller in our adolescent and child population. The ratio is more 4 to 1. And definitely the detection for anorexia amongst males is on the rise. So one of the things that I failed to mention in the prior slide is that part of the old criteria prior to 2015, one of the criteria to be diagnosed with anorexia was that you had to have an absence of 3 consecutive menstrual cycles. So obviously that ruled out 50% of the population. And so with that eliminated, I think that has definitely helped us be able to identify that males are suffering from this illness as well. And I think just general awareness that this is not a female disorder. This does not discriminate. It affects males and females alike has really broadened the diagnoses and bringing more males into treatment. So the average age of onset for anorexia is around 12 years old. It usually, not always, but it usually has some timing around the onset of puberty. And unfortunately, these illnesses have a high mortality rate. So they have the second highest mortality rate of any mental illness, topped only by opioid addiction. And an estimate of between 5 to 20% of individuals struggling with anorexia will die. Half of that is really due to suicide, and the other half is due to persisting and long-standing cardiac events and malnutrition from the anorexia. And as I mentioned before, really these individuals oftentimes just don't see that there's an issue. And as such, they're not necessarily motivated for treatment. They don't see that there's an issue, and so they might be unlikely to seek out help. Switching over to bulimia. So bulimia is when an individual engages in a binge eating episode. And so binge eating means that they are eating a large amount of food objectively in one sitting and feeling a loss of control of the time. And then in order to avoid the weight gain that might come as a result of that behavior, they engage in some sort of inappropriate compensatory behavior, meaning they're trying to compensate to try to get rid of those unwanted calories. So I think traditionally when we think of bulimia, we think of purging as the means by which they do that. But individuals may also use exercise, or they may use further restriction, laxative abuse, in order to get rid of the unwanted calories. This behavior must occur at least one time a week over the period of 3 months in order to meet criteria for the diagnosis. And much like with anorexia, the individual's view of themselves is largely colored by how they view their shape and their weight and their appearance. And bulimia nervosa itself is a distinct diagnosis. So sometimes I've heard people reference that they're diagnosed with anorexia and bulimia. You can't actually meet criteria for both at the same time. So really what we look for is what are the behaviors that predominate at the time in order to make the diagnosis. The prevalence rate for our adolescents is about 1%. And it can be more common in females, although males might be more likely to engage in excessive exercise use. So similar to anorexia, the age of onset is around 12 years old. And the thing to really keep in mind with individuals with bulimia is that unlike with anorexia, these individuals tend to maintain a normal body weight, if not slightly above a normal body weight. And so a lot of times individuals who have the bulimia diagnosis will say that they feel somewhat invalidated because they believe that by looking at them, you might not be able to know that they have an eating disorder. And so I think really the takeaway is that eating disorders know no shape or size, gender, what have you. It really crosses all, it really affects people in various different ways. And just because someone may not appear to be your classical case of an eating disorder doesn't mean that they are not struggling themselves. A key difference in individuals with bulimia is that they may be more motivated for treatment because they recognize that these behaviors that they are using are harmful to themselves. So oftentimes individuals, specifically those that purge, view it as aversive, and they might be more inclined to seek out treatment as a result. I want to touch 1 minute on avoidant and restrictive food intake disorder, specifically ARFID, because we're definitely seeing a high influx of individuals who are being diagnosed. This is a new diagnosis with the new DSM. So prior to that 2015, this diagnosis did not exist. So for these individuals, there is really a failure to meet their nutritional intake needs, resulting in low body weight. However, for them, it's really not about shape or appearance concerns. It's due to one of several other factors. So these individuals present somewhat differently, but you may have an individual who has had a lack of appetite throughout their entire life. So they've just never really had a great interest in eating. They might snack periodically through the day, but they just don't seem to have that hunger drive. Other individuals may have certain sort of sensory and texture concerns. So these individuals are historically picky eaters. And when I say picky, I don't mean your normal hamburger, macaroni and cheese, chicken fingers that we might see for most children. But these individuals have highly sensitive receptors in the sense that they have a very, very limited repertoire of food. And even within that repertoire, it's highly specialized, meaning that if pizza is one of the foods that they will eat, it's not just pizza, it's pizza from Domino's, heated at 180 degrees. And if you were to offer them Little Caesars, they would taste the difference and perhaps refuse it. And then finally, individuals who meet criteria for this diagnosis may have had an aversive event, which has led them to restrict their eating. So, for example, an individual who may have had a choking episode, or an individual who may have witnessed a student next to them at school vomit. These individuals restrict their intake because they're fearful of that event happening to them. And so as a result, these individuals may not endorse any sort of body image concerns at all. And in fact, a lot of them know that they're underweight and want to be able to gain weight. They just really don't know how. And we may also see that these individuals, it may not just be weight loss, it might be a plateau in their weight over the years, or it may be a failure to even grow as a result. But what we do know is that when the brain is malnourished, there are significant changes that happen. And as a result, some individuals who start off meeting criteria for ARFID may transition into anorexia at a later point due to the ongoing malnutrition and the impact on the brain. And then finally, the last diagnosis, other specified feeding or eating disorder, or OSFED. So these are for individuals that don't specifically meet the criteria of the other eating disorders I discussed. And so, the classic example of this would be what is sometimes referred to as atypical anorexia. And so what that means is that there may be an individual who was overweight at baseline, and they've lost a significant amount of weight, but they're not yet underweight, even for them. And so individuals might, they're doing the same behaviors that you would see with anorexia, but the weight loss has not yet resulted in them being underweight for them. So that might be an example. Or another example is when someone we refer to as prodromal, meaning that someone is eating in a disordered fashion, and perhaps they're starting to lose some weight, but it's the earlier stages of anorexia. So how we typically see eating disorders present at our center. So what we have here is a growth chart. So every time a child goes to their pediatrician, obviously they get weighed and they get measured, and the pediatrician tracks that over the years. And so for most individuals, what we see is that they will track beautifully on the same percentile for the majority of their life. So meaning at age 2, if they're on the 50th percentile, chances are by the time that they're 13, 14, if all is kind of going as it should, they'll still be on the 50th percentile for weight. In the case of anorexia specifically, what we see is that an individual will be tracking beautifully along their trajectory, and then we'll see a period of significant loss that we can see on the growth chart itself. So in the example here, we look at, this was a female who was seen in our center. And we see that she was beautifully tracking. Looks like along maybe the 95th percentile, and then over time she kind of dropped more towards the 75th percentile. But we see the big drop at around the age of 14 to the 25th percentile. Then you'll notice there's a slight bump up to the 50th percentile. That's actually because this patient went to an inpatient facility and was able to restore some of the weight loss during her eating disorder. But then the drop down shows when she was discharged from the inpatient facility. And so again, she lost weight. So this is typical of what we might see. The first thing that we really want to do is confer with the pediatrician and get the growth chart records, because it often will tell the story. So some of the warning signs that we see physically for individuals, so specific to anorexia, we may see dramatic weight loss. But again, in young children, you might not necessarily see that weight loss, but you may see a failure to gain over the course of several years. But, really to understand too that I think that a population that is often missed is like what I referred to earlier, for those individuals who might be overweight at baseline, and they may have even received messages from their pediatrician that they need to start to eat more healthy, and they will have significant weight loss, and they're often praised for that weight loss. But we really have to examine how that weight loss occurred. Did it occur through, means that were healthy, or was it due to significant restriction? We will see menstrual irregularities in females, so it would not be uncommon for someone to lose their period entirely during the course of their anorexia. Individuals may report feeling dizzy. They might have episodes of feeling lightheaded or perhaps even faint. And that is due to changes in the body, specifically with blood pressure and heart rate going from a sitting or lying down position to standing position. They may feel cold all the time. These individuals will, in the summertime, they'll be wearing full sweatsuits. They might need a heater in the summer. And I think people classically look at this and say, oh, they're trying to cover their body by wearing these baggy clothes. Oftentimes it's because they are freezing. And so they're trying to maintain as much warmth as possible. They may develop a fine hair on their body known as lanugo, as well as they might have some thinning of hair on their head and hair loss. And when these individuals receive blood work, we'll notice that they will have a low T cell count and low hormone levels, and also their heart rates are slow. So when the body is starved, it goes into self-preservation mode. And so basically it's hanging on tight, and just to use its energy, its little energy that it's getting in order to preserve life function. So everything slows down in the body considerably as a result, and the heart rate is one of those. That's perhaps one of the most dangerous things that we see, is that individuals will have heart rates that can go as low as into the 20s. And so our concern is for arrhythmias, or for cardiac arrest as a result of the individuals having these significantly low heart rates. As far as bulimia, again, these individuals may have notable fluctuations in their weight as opposed to a dramatic weight loss. They too may report dizziness and have episodes of fainting, and that's due to the electrolyte abnormalities that they have potentially as a result of purging and or exercise use. You may observe that they have cuts or calluses on their fingers, specifically their knuckles, as a result of purging. They may have dental problems, erosion due to the purging episodes. Their cheeks, their parotid glands can often be swollen, and labs may show that they have low potassium. So some of the psychological warning signs, and they really are quite similar between anorexia and anorexia and bulimia rather. So oftentimes there is a preoccupation with food and calories. So what that means is the individual is constantly thinking about food. They're constantly thinking about body. And a lot of these individuals will actually start to become obsessively interested in cooking and baking and looking up recipes. And they might prepare food, but they may not eat it themselves. Or they might be preparing food and they might be trying to feed other people, even though they themselves are not taking in the food. And we think that this is really due to that, hunger is the physiological drive at the end of it. And so that drive is still there. And so even if an individual is able to sort of suppress their hunger cues, that physiological drive remains. And so that's why they might be engaged in preparing food for other people to have sort of vicarious eating, if you will. Oftentimes they will refuse to eat in a group setting or in a public setting. So a lot of individuals will not eat with their friends. They'll make excuses to avoid going out with friends. They may not eat with their families anymore. They'll report that they've ate earlier in order to avoid that setting. Typically, they will refuse certain foods and or food groups. What we typically see, although not always, but what we typically see is that an individual starts out by limiting perhaps sweets or, fast food. And then it gradually increases to include more food groups. So maybe an individual begins limiting their carb intake, their dairy intake. And then it's not uncommon as well that individuals might become vegetarian or vegan. And really, it's not due to the ethical concerns. It's due to this is just another means of restricting food groups. They may make frequent comments about feeling fat, or specific in boys, there might be a desire to have more muscularity. They will typically engage in some sort of food rituals while they're eating. So that might mean that they are cutting their food up into really small bites, eating very slowly, pushing the food around the plate, or even having the food need to appear a certain way. They may also engage in body image rituals, which means that they may excessively sort of focus on parts of their body and whether or not that they've changed. So they might use different ways to sort of measure their body, but they also might do that just by, you know, putting their hand around their wrist or feeling their collarbone. And it's really driven by anxiety to see if there's any shape changes that have occurred. They may engage in driven or excessive exercise. So excessive exercise obviously means exercising multiple hours per day. But often what we see too is that the exercise is rather driven and compulsive. So feeling like I must engage in exercise and I can't take a rest day. There's increased social isolation from family and friends. And there's definitely changes to mood. So we may see increased anxiety or depression, irritability, and really at its most severe, we see that an individual actually just becomes very flat in their affect. They seemingly have no emotional expression. It's referred to as cognitive dulling. So there's just limited emotional expression. So with bulimia, again, we see some commonalities between this diagnosis and anorexia. Some of the differences that we can see with bulimia is that parents might report that there are large amounts of food that go missing from the household. They might find wrappers or remnants of food in their child's room. There might be evidence of laxative use, or misuse rather. They may have frequent trips to the bathroom after meals. But again, most everything else pretty much parallels what we see with anorexia diagnosis. So when I meet with parents for the first time, the first question that they often have is, what caused this? And so really, I tell them that the short answer is that we don't know. The long answer is that we have evidence again that these illnesses are biological in nature. So, it's really that their genetic vulnerability predisposes them, and there are certain environmental factors that bring it out. So really, genes play a major role. We know that most individuals who develop an eating disorder often have a first-degree relative that has also been afflicted with an eating disorder. So a mother, a father, a sister, an aunt. And it's really perhaps the research suggests due to a difference in the brain of individuals who have these illnesses. So specifically, it's thought that individuals who develop anorexia specifically have a high level of serotonin in their brain. And through not eating, through restricting their intake, it actually brings the serotonin down to more normative levels, which means that restricting is actually a coping mechanism, or can be a coping mechanism for individuals, and that it actually does make them feel better and less anxious by engaging in restrictive behaviors. There's also thoughts that these individuals have an altered reward system. So what does that mean? So, the process of eating. So basically what happens is if I have a donut in front of me and I take a bite, there's a message from my mouth to my brain that says that tastes good. And then my brain sends the message back saying, take another bite. So they believe that pathway can be disrupted in individuals. And so one of the studies that they've done is they've actually done MRI studies of the brains of individuals with and without anorexia. And so what they've done is they've put them on essentially a fast for a period of time. And then they've introduced food to them after that fast. And what they found is that individuals who do not have anorexia, the area in their brain sort of lights up as soon as they get access to that food. whereas individuals who do have anorexia, that area in the brain does not show any activity. And it's interesting because when I talk about the personality types associated with these illnesses, a lot of times these individuals seem to be more driven by the fear of consequences than by rewards. And finally, there's some traits, temperamental traits that we see in individuals that really seem to correlate with later development of an eating disorder. So specifically, most of the individuals that we see tend to be highly perfectionistic. They tend to be people pleasing. They want other people to think really well of them. They are what we refer to as harm avoidant, meaning fearfulness of making a mistake. They're rule bound, and as a result, they can be somewhat rigid. So I'm going to circle back to that, but I want to first talk about the effects of starvation on an individual. So believe it or not, a lot of what we know about the effects of starvation is from an experiment that was done in the 40s. And so it was World War II, and researchers wanted to study what are the effects of starvation and malnourishment on the brain. So what they did is they recruited 36 male subjects, and they essentially put them on a starvation diet. And oh, hold on, my slides are stuck. There we go. So what they found is that psychologically, these men, when they were in the period of starvation, they developed a preoccupation with food. So these men in the 1940s began trading recipes with one another. They were increasingly irritable. They couldn't focus. And then in terms of physiologically, they had a decreased heart rate. They were sensitive to the cold, and they had changes in their hair and their skin. So again, not unlike what we see with anorexia. It also, though, this study had a profound effect on how we view recovery. So what they found with these individuals is once they were through sort of the phase of starvation with them, they obviously had to nourish them once again. And what they found is they tried all sorts of different diets and calorie loads. And what they found is really that it was all about calories. It was just these individuals needed a high amount of calories in order to get their brains to think differently about food. And this has really had an impact on how we approach treatment now. So when we combine sort of those two factors, the best way really that I can explain it is this. Most people at some point in their life will go on a diet or will change their eating habits to perhaps choose to eat in a more healthy way. This is a decision that many people make. And for some individuals, though, unfortunately, they are predisposed to this illness so that the process of dieting or eating a little more healthy for them quickly spirals out of control. So for where, an individual such as myself might say, again, okay, I'm going to go on a diet. I'm going to try to eat a little more healthy. And then, I'm at a party. They have pizza, looks great. I'm going to have pizza, cake, forget the diet for today. Individuals who are more prone to develop anorexia really stick to and adhere to that rigid way of eating that they establish. And then over time, they just become more and more limited with their repertoire until that process of starvation sort of kicks in. And once an individual is malnourished, we know from the key study that there are significant changes that happen to the structure of their brain, which really renders them incapable of getting out of it on their own. So I want to review some of the myths associated with eating disorders. So the first one, of course, the hot topic for right now is social media and social media's role in eating disorders. So, obviously we know that social media can have a negative impact on how individuals see themselves. But what I say is that, if social media caused eating disorders, we'd all be walking around with eating disorders. So listen, they're messaging on, these various sites. Is it poor? Is it misinformed? Yes, absolutely. But again, it really has that to do more with that certain individuals are predisposed to receive this messaging in a different way. So if social media, if these individuals are viewed as sort of more authority figures specifically that are disseminating information, an individual who's predisposed to an eating disorder might be more inclined to believe that information, and then to use some of the tools or whatever strategies that these individuals are recommending. Eating disorders are a choice. So I think this is still a widespread belief that an individual chooses to have an eating disorder. And again, what we know is that individuals don't choose this. So even if they made the choice to eat more healthy or go on a diet, that is not, a decision that is unlike another individual. Again, they don't know that their specific genetic makeup makes them vulnerable to develop this disorder. We know that parents don't cause eating disorders. A while back, it was really viewed as more of a family issue, and that's really an outdated understanding of eating disorders. We know that parents are not a causal factor. We do know that they're essential in the recovery of an individual, however, with an eating disorder. An eating disorder is not that serious. So I mentioned some of the medical complications that can occur. It is not uncommon that sometimes individuals require a hospital stay in order to stabilize them, their heart specifically, before they're able to receive additional treatment. So usually what we will see in that scenario again is that a heart rate is so low that an individual must be monitored in a hospital setting prior to getting the eating disorder treatment that they need. Again, really focusing on sort of causal factors and motivation. So individuals with the eating disorder may not pursue treatment. They might be unwilling participants of treatment. So even if parents are able to get them into treatment, the individual themselves might not be motivated to complete their meals or to stop the purging behaviors, because for them, they might not see it as harmful as it is, or the fear of what comes with the weight gain or what have you really outweighs any potential benefits in their mind. This does typically improve the further they are into treatment. And then finally, I'll touch on my child is too young to have an eating disorder. So here at the center, we see children as young as 8. And when we see children, we do see that they meet full criteria for anorexia. So even at that young age, we do see these illnesses presenting. So I will review some of the treatment. First, touching on the goals of treatment. So for anorexia, really what we're looking to do is we are looking to reverse the medical and the psychological complications. So first and foremost, we need to ensure that an individual is stabilized medically. And that's what makes these illnesses so unique, is that they are medical and they are psychological. But really the focus is on first, we need to stabilize where they're at medically. And what we know, and especially from the key study that I've referenced, is that in order to get an individual back and to get their brain back functioning as it was, they need to be fully restored to the weight that is appropriate for them. So going back to that growth chart I showed earlier, so that individual was historically on the 75th percentile for their weight. That's where they're going to need to return to in order for those changes to happen in the brain. We also want to make sure that we interrupt the eating disorder behavior so that the individual is no longer able to restrict or use food rituals. We want to make sure that we're giving them all the foods that they were avoiding during the eating disorder, often referred to as fear foods. And ultimately, the goal is to get them back into a normative pattern of eating, being able to respond to their hunger and their fullness cues. In bulimia, too, we are looking to reverse the medical complications. Here, the focus is more on weight stabilization, meaning to prevent those fluctuations, those bigger fluctuations. Um, Making sure that we're interrupting whatever compensatory behaviors that they're using, whether that's excessive exercise or purging, and then making sure that we're introducing the foods they were likely to binge on in more moderate amounts.
So it would not be uncommon that individuals might be restricting their intake throughout the day, but then when they reach binge episodes, might be eating all the foods that they don't allow themselves to have during the day. And we want to make sure that they can have those just in a more moderate fashion. Regarding the levels, so the different levels of care for eating disorders, starting at, I guess, the most restrictive, is in inpatient settings, specifically individuals who are either medically unstable or significantly underweight with intense symptoms may be recommended for inpatient. Inpatient means going to a hospital setting where an individual is there overnight, 24 hours a day, 7 days a week, so they can be monitored by staff. Typically, the average length of stay is about 4 weeks or so, and the goal is to get the individual to a stable enough place where they can step down into a lower level of care. Residential is also around the clock care. And the difference here is that, first of all, it is a longer term stay, generally speaking. On average, I see that most individuals will go to residential for about 1 to 3 months or so. So here, an individual is not medically unstable, but they might have persistent symptom use. They might be they might be weight restored, but they might still be struggling a lot with the thoughts and the behaviors associated. And so they might need to go to a setting where they can stay longer to practice feeding themselves independently. Then from there, we have partial hospitalization programs, otherwise known as day treatment. And so in these facilities, an individual will go for the day, but they're able to go home at night. And so really, again, the goal is on focusing on getting the individual to eat in a more normative pattern and to introduce those fear foods and to get their weight increased. Then below that, we have intensive outpatient. So this is programs where they're typically in a facility, maybe from about 8 to 12 hours a week or so. It's often a step down treatment from a higher level of care where they're more integrated back into sort of their lives at school, what have you, while also continuing to receive treatment. And then finally, outpatient treatment, meaning that they're coming in to either see their therapist, their nutritionist, what have you. So those were the levels of care. Now I'm going to speak to what are the specific, what we call treatment modalities, like how is treatment delivered. And so the first way that is, I'd say, even still pretty routine these days, is an individual will receive what's known as traditional treatment. So traditional treatment means that they will have perhaps a therapist and a nutritionist who they work with on their eating disorder behaviors. And so the idea behind this is that an individual themselves needs to really focus on making the changes necessary for lasting change. Conversely, we have family-based treatment. So family-based treatment is a form developed as a form of outpatient treatment, but unlike the traditional approach, it says that right now the individual is too malnourished and their brain can't think appropriately about food. So we need to take that away from them. We need to put the parents in charge and have the parents responsible for making all food related decisions. So that might mean that the parents are choosing all their child's food, preparing it, portioning it, supervising it. again, really focusing on that the parents are taking this over to make the changes necessary to help the child progressively gain weight. So FBT, family-based treatment, is the only evidence-based treatment that there is for anorexia. So meaning that it is the only researched and the only treatment that has effective, proven effective outcomes. And it happens to be the one that we use here at the center. Finally, we also have cognitive behavioral therapy. So there's a specific protocol that was developed for anorexia and bulimia. So it is an individual approach. So oftentimes we may use this with our older adolescents or young adults. And, you know, it really focuses again on that individual making the changes, but it's done in a very structured way and follows a specific protocol. And so usually this type of treatment is more effective for your motivated individual who is really wanting to make changes to their eating behaviors. So I'm not going to go into, in the interest of time, more detail about FBT treatment and CBTE, but just to understand sort of the treatment that we provide here at the center. So first of all, we are part of Goriab Children's Hospital. We are located at Overlook Medical Center in Summit. We're the only multidisciplinary program in New Jersey that's exclusively for children and adolescents. So what that means is that, as I said, we treat ages 8 to 21, and we do not treat adults as part of our program. And so really we are developing programming specific to the child and adolescent population. So the individuals that are here, working here, are trained specifically, the physicians are trained in adolescent medicine. The psychologists, social workers, LPCs are trained in child and adolescent psychology. What's also worth mentioning is that we are the only partial program in the state of New Jersey that offers medical care as well. Because we have our physicians on staff, we are able to take children and adolescents who traditionally might be referred for an inpatient setting because we have the capability to manage those medical complications. FBT, the type of treatment that I talked about, the evidence-based treatment, is infused into all levels of care. So an individual will start receiving FBT when they come into our program, and we continue seeing that individual as they progress through the different stages of outpatient until they're in remission from their eating disorder. And then finally, and again, in the interest of time, I'm just going to touch on this briefly. You know, with COVID, we definitely saw a dramatic uprise in the frequency of eating disorders, and like other mental illnesses that definitely increased with the pandemic. And so I think, you know, the reasoning really behind that is twofold. So first of all, you know, as I mentioned, these children really yearn for structure and routine. And so what had happened during quarantine, we lost that sense of, you know, predictability. And so for these kids, they were sort of lost. They didn't know what to do without that kind of predictable routine. In addition, we know that there was increased exposure to social media as sort of a platform for, you know, being able to have any sort of social contact. And a lot of the messaging on social media at the time was about, you know, exercising and eating and making sure during the pandemic that you don't gain weight. And so again, having this vulnerable subset of individuals who you've taken away what they're used to every day, and then they're exposed to these messages, led to sort of this heightened degree of eating concerns, which really led into an increase of what we saw at the center. And there was not an access to healthcare. You know, healthcare systems were overloaded and inundated, and it was very hard to be able to get eating disorder treatment at the time. So we actually did a study here in our program, and we looked at the differences between individuals who were treated at our center before COVID and after. And we found that, those individuals who received treatment after COVID, there was a greater rate of hospitalization for individuals prior, meaning that individuals who sought treatment after COVID were more likely to have to go to the hospital first, due to the severity of their symptoms. And again, that's more about sort of the lack of access to healthcare at the time. But what we did find, and we also, what we also found is that when we discharged these individuals, there were greater psychiatric concerns. So increased anxiety and depression, as well as suicidality. And we believe that that's because these individuals were not really going back to anything either. School was not consistent and not, definitely not in person for a lot of individuals. So they were kind of going back to the same setting. And so we think that that led to sort of those increased mental health concerns. But one of the fortunate things we saw is that looking at outcomes, we saw no difference at all in the outcomes of individuals who were treated, meaning that restoration for weight, how they were able to proceed through treatment and recover was essentially the same between the two groups. So with that, I am going to pause for questions, and I am happy to address any questions that you might have.
Thank you so much, Megan. At this time, I'd like to remind everyone that the Q&A is open. We do have a few questions currently in there. The first being, does your center treat young adults age 19 with high functioning ASD, no communication, or intellectual disability?
Yes. That was an easy one. Yes, we do. So we treat up to 21. And generally speaking, yes, we have treated many individuals who are on the spectrum. And yes.
And does your treatment for ARFID include occupational therapy, given the sensory related aspects that may be associated with the disorder?
Yeah, great question. It doesn't. It actually doesn't. And we use a very specific, and I know I didn't go into detail in the presentation. We use a very specific type of treatment for ARFID. It's known as CBT-AR. And really what it does is it works on exposure, gradual exposure of, least preferred foods, and working on introducing them in small amounts, with the parents having to introduce them at home to continue the repetitions. Because what we find is with these individuals is that once you sort of repeat and consistently repeat exposure to these least preferred foods, there tends to be more acclimation to them. They just require, individuals who are diagnosed with ARFID just require more and more tastings of these foods to really determine whether or not there's something that is preference or not. So there are some facilities that do use OTs in their practice. It's not something that we have used here, but I can definitely understand where that question comes from.
All right. And what type of success rates are there for these types of eating disorders?
Yeah, so great question. So basically, what we know about sort of success rates. So when we look at traditional treatment versus family-based treatment, I think that's the easy way to kind of look at it. So with using FBT, success rates have been found to be anywhere between 50% and 80%. And I know that's quite a high range, and it's really just dependent on sort of the research that was done, and what they were looking at. But as I mentioned, FBT specifically has the highest rate of success of any of the types of treatments. And so, I think that really that what we see here is that for those individuals who are able to complete the treatment protocol as intended, there's great success with it. Conversely, what we know about traditional treatment is that generally speaking, the research suggests that it's about 25% success rate with traditional treatment.
All right, and the last question I have right now is, where should a parent begin if they suspect that their child has an eating disorder?
Yeah. So I think that I would begin by taking your child to the pediatrician. So the pediatrician is, able to kind of hopefully suss out some of that. But as well, they're going to have the most up-to-date weight information. They're also going to be able to look medically at how the child is doing. And so I think that's really the first best place to start, is to just bring your child to their pediatrician for a visit. I think it can be really hard because, like I mentioned, a lot of individuals are not necessarily motivated, and there's a lot of secretive behavior that's involved in an eating disorder. So, and a child might not be completely transparent about what they are suffering from. But I think that really to trust your parental gut. If you think that something is happening, it likely is. And first and foremost, to consult your pediatrician if you find that your concerns are not being addressed appropriately. Then I think you need to start to do your own research. There's a host of available resources online, but also to perhaps speak with certain mental health professionals. And again, it doesn't have to be to come in, but it can just be to consult and say, hey, this is what I'm seeing. Do you think that this is something that I should be concerned about? And hopefully then be able to get some guidance that way. So, one of the things here at our center is that we will perform a phone assessment on individuals that call, or for individuals that call. We'll speak with the parents and kind of get a sense of what's going on. And then, determine, hey, is this is something that we think that you could find a therapist in the community for, or, you might need to come in here. So, just because someone contacts our facility doesn't mean that they necessarily need to be seen here, but we can give some guidance as well.
Awesome. Thank you so much, Megan. I don't see any more current questions in the Q&A. So at this time, I would like to say thank you all for joining. We kindly ask that you take a few minutes after today's webinar to complete the program survey. The link to the survey has also been added to the chat for your convenience. A special thank you to Megan for dedicating your time and your expertise today. And if you have any additional questions or comments, you can send an email to communityhealth@atlantichealth.org or by calling 1-844-472-8499. Thank you again, and this concludes today's webinar. I hope you all have a great day.
Thank you.
Thank you.